we have here somebody who, you have so many like titles and things you're doing, I don't even know where to begin. She just got nominated as Doctor of the Year by the Providence Business News, right? Is that what it was again just today? But this is Dr. Megan Ranney. She is an emergency room physician. I'm sure she'll tell you about that. She was also the co-chair of the Governor's Commission on Gun Violence that was just convened last year. She co-chaired it with Colonel Manny, who is the new superintendent of the state police. We met Dr. Ranney because she came and testified at hearings years ago, and I remember her walking out and just saying, like, nobody was even listening to me. Like, well, I don't even know why I just did that, even though she gave such compelling testimony about her experience of seeing gun violence right up front. And right now she is one of the founding members of a group called AFFIRM, which I'm going to let you tell people all about that, which is really exciting. She's doing some really wonderful work, not only just in Rhode Island here as a physician and in the gun violence movement, but also nationally. So we're really thankful that you were able to come and talk to us. So we know you're so busy. So thank you, Dr. Ranney.
Thank you. Awesome. So I figured I would talk for a few minutes. Linda had asked me to talk a little about kind of my perspective on gun violence as a public health problem rather than as a criminal justice problem. And then I thought I'd open it up for questions and discussions. And I'm going to apologize for being late and for missing your story, Lisa. I was actually working in the emergency department tonight, and my shift ran late. It was a really busy night at Rhode Island Hospital, so that's why I'm a little late, so I apologize. Thank you for that introduction. I am an emergency physician. I work at Rhode Island in Miriam and occasionally at Hasbro. I've been here in Rhode Island for 15 years. Both my kids were born here, so they're now Rhode Islanders, although I am not. I was born and raised in Buffalo, New York, and kind of lived all over kind of along my way and came here for my training in emergency medicine. Then stayed on to do a fellowship in injury prevention because there's a whole science of preventing injuries, including violence. And then stayed on as faculty and have never left. Really kind of have fallen in love with the state and the people and the clinical care that we provide at Rhode Island and Miriam Hospital emergency departments, despite challenging circumstances sometimes. So I apologize for any of you that have been in our EDs recently and had to experience the craziness. My perspective, I come to gun violence from a few perspectives. The first is as an emergency physician. Taking care of gun violence is part of our bread and butter of emergency medicine, for better or for worse. All of us in emergency medicine across the country train at trauma centers. And at every trauma center across the United States, you are going to see victims of firearm injury on any given Friday, Saturday night, and in some trauma centers every night of the week. And learning how to take care of firearm injury is one of our basic skill sets. We do extensive training before they kind of let us out loose with patients, and then continue to do training throughout our residency. And part of the training, honestly, is learning how to become a little emotionally numb to it. You can't take great care of patients if you're hugely empathetic in the moment. If you're feeling all the pain that they're feeling, you're going to get distracted and not do a good job making the right decisions to save their lives in the moment. And I think that happened to me just like with everyone who goes through training. And then I had a series of experiences late in my residency and early in my attending years that really reminded me of the degree to which firearm injury is something really different from anything else. And I'm going to talk about those in a little bit. So that's my first perspective. My second perspective is as an injury prevention researcher. Like I mentioned, I did do a 2-year training in the science and the research methods of injury prevention. I went into that knowing that I wanted to do violence prevention. It's something that I've worked on, honestly, since high school. Thought I was going to focus on sexual violence and domestic violence because that's a lot of what I had spent my time on kind of in high school and college and med school. But as I started working on it, and at that point was working with Institute for Study and Practice of Nonviolence and a little bit with Day One, I got real interested in gun violence, partly because of the stories that I'll share. and was very explicitly told that I couldn't talk about it. That gun violence was something that as a researcher and as a clinician, I couldn't have a voice on. Not that it was illegal per se, but that I would do my career as a researcher, that I would never get federal funding. I would do my career in general. And that changed over time, and I'll share the stories of that as well. And then my third perspective is as a parent. As I said, I have 2 little kids. They're 7 and 10 now, and that shapes my perspective on this every single day. My kids are a huge part of the reason that I do this, and then by extension, everyone's kids, right? So I'll start with the clinical stories. And then I'll talk kind of about the bigger picture. So the clinical stories, early on, so taking care of community violence is something that we just do. Again, we become somewhat inured to it. We talk about it. Those of us that care about social determinants of health care deeply about the fact that the patients that we take care of in the emergency department with firearm injury are predominantly minority young men. And we do a lot of talking about it, but when it comes to the moment of taking care of a patient, like I said, you put on this kind of front and you just take care of the patient. And then I had a couple of cases. One was a young man who came in and had shot himself in the head. And it came in the same way as any other gunshot wound. We got the notification over the radio, GSW, trauma code. We all thought that we were expecting what was coming in, had the trauma team get together. And then the patient rolled in and the air kind of went out of the room. Because it was something that none of us had ever seen. And at that point I didn't realize the degree to which 2/3 of firearm deaths in this country are suicides. But most of them never make it to my doors. And now 15 years later, that's still the only time I've ever seen someone who survived to my ER after trying to commit suicide with a gun. And it just, I think it took all of our breaths away because it exposed that degree to which we put up this wall around these clinical experiences. I think it exposed a lot of internalized beliefs in a whole lot of different ways, and it really made me start wondering, why is it that I've never seen a suicide with a gun? I mean, we see suicide attempts every single day, many of them a day, and they never die, right? And I started looking into it and realizing again that 2/3 of firearm injury deaths in this country are gun deaths, are suicide deaths, and that 90% of suicide attempts with a gun are lethal, versus only about 10% of suicide attempts with any other means. And that experience really highlighted to me again the degree to which guns are different and how we have to talk about them differently. And then I had another experience, which was a domestic violence case. A woman who was threatened by her boyfriend with a gun, wasn't shot, but I remember calling the police because she didn't have any injuries that required her to stay in the hospital. And she knew that the moment she went back out on the street, he was going to find her and kill her. And the police were like, if we run into him, you know, I was like, I can't believe I'm sending this woman back out. And that was kind of the second thing that made me say there's got to be something else I can do. And then the third one was a young girl that we took care of at Hasbro, who was kind of well known in the news for those of us that have been in the city for a long time, in the area for a long time, who was shot, kind of a random bullet went bad and went through her house and killed her at home. And that family's grief is something that will never leave any of us that took care of her or encountered that. And those are just 3 of, you know, dozens and dozens of stories that I or any other ER doc across the country have. So then I took those clinical stories, and I'm not someone who kind of takes things and says, I'm just going to sit with these horrible things that happen. I took those, and then I took that violence prevention training and the fact that I had been told not to talk about guns. And I started to say, well, maybe I can do something about it even though I've been told not to. So I started looking at shooting and stabbing deaths, and so it started trying to talk about it in ways that weren't specifically talking about guns. And that's where I started to do the research to look at the % of gun deaths that were suicides. And I started looking at the difference in fatality rates between assaults with a gun versus assaults with stabbings or blunt force assaults where someone's punched or kicked or hit. And I started trying to look for risk factors to say who's at risk of being shot. And again, you kind of identified that there are these really, this bimodal distribution of gun deaths in this country. We have young minority men, 15 to 34. Firearm injury is the second leading cause of death for children and adolescents in this country, and it is the leading reason for adolescents to die in this country. It is a disease process that disproportionately affects minorities, and is something that we must talk about as such. And then there's the other epidemic. When you actually look at the raw numbers, over 60% of gun deaths in this country are white, middle-aged men. And again, that's something that we just don't talk about. We don't see it so frequently here in Rhode Island as in kind of the Midwest or the South and Alaska, where the gun death rates are just insanely high, and it's almost all suicide there. And so started thinking about the way in that there's another silent epidemic. You know, one epidemic gets hidden because people don't want to talk about it, and they talk about it as criminal justice, and the other epidemic gets hidden because it's about mental illness and stigma, and about people not wanting to talk about how this affects them. And so started kind of trying to do research and look at this as a public health problem, the same way that I look at car crash deaths or the opioid epidemic or cigarettes. I know that we've successfully decreased car crash deaths by over 50% using really good science. And so started trying to think about ways that I could do that creatively, and that was probably about the point that I testified probably 6 or 7 years ago. And then there was that third part of being a parent, and Sandy Hook happened, right? My daughter was 4, and I was actually sitting in a faculty meeting and watching the images come across my phone at that point, and thinking of, I have friends that live down there whose kids are a little bit older than mine and a little bit younger, and thinking about how easily that could have been any of our kids. And then again, bringing in those two other parts of, this could be anyone's kid's any's day, but this one just happened to be a really big, really bad thing that caught all of our attention. And when Sandy Hook happened, I think it enabled many of us who'd been trying to talk about this for a long time to say now's the time to have a voice. And so at that point I started working within my medical society and other medical societies to try to change the discussion around gun violence, to make it something that wasn't something that we had to be silent on, but rather something we could talk about as a medical issue, something where we could share these stories of the patients, their families, the communities, the effect on the doctors, the effect on the nurses, the respiratory techs, the EMTs who take care of them. So working within my College of Emergency Physicians, then the American Medical Association, started testifying here, working locally and nationally, and kept thinking, well, this is going to change, right? Something's going to change. People are going to see that this is an epidemic and people are dying. And meanwhile, the number of people goes up year after year, and that's why you guys are all here, right? Because there's over 100 people that die and over 200 that are injured every day across the United States. And then that was the moment when I and my co-founder of AFFIRM decided to create AFFIRM. And what AFFIRM is, it's the American Foundation for Firearm Injury Reduction in Medicine. And Tracy Hauver, who I know couldn't be here tonight because she wasn't feeling good, has been a big part of it. I know she's been a big part of this group. And our goal is really kind of complementary, and it's something that's not being done by anyone else in the gun violence prevention world. I think the work that's being done by the Rhode Island Coalition and by coalitions like us across the country are critical. But we also know that we have never solved a public health problem in the history of the United States without good science. And it's through good science that we develop solutions that are not stigmatizing and that are effective and that can be effectively disseminated. And policy is critical, but it is not sufficient. Look at texting and driving, right? Like, our state has a wonderful law about no handheld cell phones, and I will be honest, when I sit at a stoplight, I check my phone, right? And I'm sure that many of you are the same. I don't check it while I'm driving on the highway, but I sure as heck see people that do that, right? And so there's an element of education, and when you look at how we've had successes in decreasing motor vehicle crashes, laws are part of it, drunk driving laws, speed limits, etc. But it's also working with the automobile manufacturers, and I'm not saying that we have to completely double it, but it's working to get seatbelts in cars, it's changing the design of cars, it's doing education around drunk driving, it's driver's ed courses. We also know that there's some stuff that we've tried that hasn't worked or has made things worse. And here I think about other epidemics across our history, like opioid epidemic or HIV, or kind of other forms of drugs and substance use. And I think about the ways in which we think that some things will work and then they don't. And that's why science is so critical. We need to try things, but then we need to make sure they're actually making a difference and that we're not spending our efforts and our money on something that's making things worse. And so the point behind AFFIRM was, we kept lobbying the federal government to get funding for research, and it's still not there. CDC still has $0 in appropriations, NIH has less than 2% spends less than 2% of what it should on firearm injury. There are a few big grants, which I've been lucky enough to be part of, and there's just not enough of it out there, given the burden of injury. Again, the fact that this is the second leading cause of death for our kids, the fact that this is the first leading cause of death for our teens, the fact that the mortality rate has gone up from when I started working on this to from around 10 per 100,000. Now it's up to about 12 per 100,000. Like year after year, the number of people dying keeps increasing. And we still have science at the same level that it was at back in 1996 when the Dickey Amendment was passed. And so the point of AFFIRM is twofold. So one is to create private investments into this problem, recognizing we're not going to replace federal funding, but that we can be nimble and innovative and jumpstart the research that's so desperately needed, that's been absolutely missing for the last 22 years. And then the second part is to bring that collective will of medicine together, to bring those voices of physicians and nurses and social workers and public health professionals together to share these stories, and to make it possible for other people to share these stories too, as I know that you guys do here as well, so that this epidemic is not silent. I think one of the things that has most affected me as I've done this work around the country has been the number of people who come up to me afterwards or who call me or email me and have these tremendously personal stories that, just as I had tucked away those personal experiences in the ER, they've tucked away and not thought of it as their family being affected by gun violence, right? People, oh, you know, my grandmother was killed by her husband, or my cousin committed suicide, or these stories come out. And at the end of the day, almost every one of us has one, right? And I think that if we all came out and told those stories, this epidemic would not be silent, and you better believe that we'd have investment in it. I think of it in many ways like the civil rights movement or the gay rights movement. It's about knowing people and knowing that people just like me are affected. And for too long, we kept it cordoned off and said, this is a criminal justice problem, and if we start treating it as a public health problem instead, we can talk about how it affects every one of our communities and every one of our children across this country. And so that's our goal with AFFIRM, is really to both, again, represent that collective will of medicine and then to jumpstart the much needed research. Through the public health approach, there's a lot of things we can do. There's, like I said, there is this science. There's kind of three big things. There's education, there's engineering, and then there's enforcement. And all three parts are critical to effective injury prevention. But we don't even have the basic data at this point to start developing those interventions, and that's what's so needed. I'm certainly, when I give talks to physicians or to nurses, I talk a lot about kind of what we do know and the various risk factors that are out there. But we can do so much better in terms of identifying folks who are at risk before they hurt themselves or others. We can do so much better in terms of helping docs and nurses and social workers to have protocols. I mean, we don't even know, I think about that domestic violence case that I told, and at that point, it was before our ERPO was passed, right? There was nothing I could do, and I was like, well, she gave me permission to call the police, but what if she hadn't, right? Am I allowed to call? What's the right thing to do? And so trying to provide that kind of education so that the people who are encountering these often kids or young adults can have something that they can do effectively. And then, again, making sure that it works to keep us safe. So I'll stop talking there. I don't want to talk too long, but I certainly welcome questions, and I'm happy to talk more about specific topics if you're interested.